Good morning, everybody. I really dislike people who breeze into meetings as though they're terribly important and don't come to the beginning of the meeting. So I'm not one of those people. I'm somebody who doesn't know how a diary works. Anyway, my name's John Parry. I'm a GP. I'm the clinical director of TPP System 1. I realise the title's slightly tautologist, but anyway, I'm going to talk about a little bit about electronic medical records and how they join things up. I put this slide up first to reference that I know what we're talking about, so that's great, but also as a reminder that, of course, one of the key things for the pharmacy side of what we're talking about is the fact that we use a separate drug database, which we buy in from First Data Bank, their multilex drug database, and obviously any discussions moving forward about how the genetic sides of prescribing gets integrated into clinical systems, they will be a very important partner in that conversation. For those of you not sure what we do, TPP was a company formed about 20 years ago. I, at the time, was a GP. I wanted to have the same GP record available when I was working in the GP out-of-hours service. I also have a friend, Richard Pope, who's a diabetologist. We wanted the same record available for patients in having diabetic care at the acute hospital. So we went out to tender and commissioned TPP to deliver this. It's now grown. We're the second largest GP system supplier, but we also have palliative care, community care with the National Prison System, and so on, and into acute care as well. And just this slide is just to show you some numbers. Numbers are always telling. These were numbers in February 2017. So we did 150 million ETP prescriptions through System 1 in February 2017. So there's an awful lot of data going through the system, very large numbers of things happening in some very large servers. And obviously the scale of that means that the data that we have in our systems is terribly important to move this agenda forward. Our users have access to a comprehensive clinical reporting suite which allows them to do some of the things that you've been alluding to in terms of clinical reporting, to find groups of patients who meet certain criteria. It's very easy to do within the system, and over 10 million reports are run every month on the system. But of course, the things that we just mentioned a few moments ago, the issues around quality of coding, how things get coded, how it gets translated from the index case into the affected individuals in the family tree, I think are important questions, certainly. I just want to pause for a second and just think about the prescribing side of things, where we've seen how many of these prescriptions are generated within the system. But I'm trying to get a feel for what is the data set when we talk about sharing for data, and I'm going to come on to some of the interesting conversations we've been having with the Information Commissioner that you may or may not be aware of. If you're a Telegraph reader, you certainly will have seen it on the front page. There are lots of elements to prescribing. Obviously, when you're starting to prescribe, you create an intention to prescribe, but you also have to have an awareness of the current medication load, and that may be coming from multiple providers in the NHS at the moment. We also need to know the past prescribing experience for that individual patient, including any adverse reactions. Pre-existing conditions, monitoring of both their pre-existing conditions and the effect that the medication is having on them. I think of renal function, particularly with NSAIDs, with patients with heart failure. And of course, compliance. I mean, we don't have a feedback loop at the moment from the dispensing that's going on in the community back into the GP system. That loop of electronic prescribing is missing. It's only obviously a marker for compliance. We still don't know whether the patient's actually taking the medication, but that's a missing thing. And the data elements that we're interested in and that we try and supply with our shared record system and increasingly with the interoperability work, which I'll come on to in a minute, are listed here as well. Obviously, the demographics and the coded data are very important because they allow us to interact with computerized decision support. But of course, for many patients, when you're actually dealing with, and as previous speakers have alluded to, we're trying to stratify our patients as we see them, we get an awful lot of that information currently from documents from secondary care and other providers. And that access to that rich, full record means that you can at least have a better go at trying to work out what's happening. And of course, there is important information within the free text of the record. And then, of course, there are other things which are less structured, although people are working to structure these much more at the moment, as care plans and pathways of care and so on. And so we always have this issue when we're dealing with an interoperable computerized record, how complete is that record? Now, the interesting few weeks I've had talking to the Information Commissioner gives the reason for the final arbiter, which is an odd expression. But sharing for direct care is a fine example of the difficult balance between the benefits and demands of our citizens, our patients, and of course the role of the data controller, who has the final legal responsibility for how records are shared. We obviously have an approach to consent, but consent is not adequate for fair and legal processing of data. We do obviously have to make sure our citizens are fully aware of how their data is processed. And it's interesting that the ICO's recently published advice on big data and risk stratification, and it's a very good document actually. It's a very helpful, well-balanced document about how it's very important that we don't process beyond what's reasonably expected by citizens, or at least if we do make sure that they're informed adequately. The particular issue that we came up against recently was that in order to make a clinical record available wherever the citizen may choose to seek care, technically in data protection terms, that record must be disclosed in readiness for its use. It's something that the Information Commissioner said that they'd only really sorted out in their heads when they were dealing with the issues around our sharing model in System 1. And it's something that we're working very rapidly to sort out with the ICO and NHS Digital and NHS England. But it has highlighted a very, very important point, that if we want to have standardized, computerized clinical decision support for patients based on all the work that's being done in personalizing medicine, we need to have a mechanism whereby that record is available at the point of care so that it can interact with the appropriate decision support software. Now, one of the approaches to this is to actually make sure that that is government policy. If the NHS would say that that is their intention, then that would provide some justification for the Information Commissioner to actually make a stand more in support of more widespread disclosure, and that's something that's being talked about at the moment. The other aspect, of course, of sharing for direct care, and this is a troublesome word, is proportionality. The GMC guidance that comes into force in a couple of weeks' time talks much more and very helpfully about the need to share information for direct patient care, but still proportionality is key to this. And proportionality to me, I think, is a stumbling block when we're talking about computerized decision support to support stratification and all aspects of prescribing and care, because if you have a limited data set, you don't know what you don't know, and we don't know yet from the big data research what aspects of a coded record will influence the outcome for that particular patient. So the data is incomplete in many situations for obvious reasons. I've just listed a few of them there. We've talked about data quality already. I mean, poor data quality is a real issue. One of the aspects, I think, of the pressures on general practice at the moment is that I think data quality may decline. We've had a great 10, 15 years where GPs have put enormous efforts into creating and maintaining the patient's long-term record, and there've been some financial support to do that. But I always think that data quality is the victim of time pressure in this situation. Patient choice, or citizen choice, we will always be mindful of what the citizens' desires are. Of course, it's unfortunate. I'd hoped that we could have talked about the government's response to Dame Fiona Caldicott's third report, but it's still not out. I'm sure there are people in the room who probably know more about it than I do. Obviously, the data controller, as we have learnt in the last 6 months, is a very important choice that has to be brought into this as well. And then we have the other technical issues we have. I put the Proteus Discover thing just to remind me. I talked about compliance earlier. We don't know whether the patients are taking their medication, but obviously there are those who would like to get to the point where we can monitor what pills are being taken, but I think we're a little way off that at the moment. Pharmacogenomics is something I would really love to see up and running in our systems now. I think it's probably readily doable in advance of the complexities of some of the other things that will come. I'm particularly interested in this one. 2 of my children have a purine metabolism abnormality, which means they have gout. My daughter had gout at 16. She also had a nasty allergic reaction to allopurinol. And that's all very important for her. But what's most important is that I had an attack of gout 3 weeks ago, and I'm facing the prospect of having to take allopurinol, and I want to make sure I don't die of this particularly vicious allergic reaction. So this particular genotype is of particular interest to me. And obviously I've put this up to make sure that Munir knows that I've been looking at what he does. But the point is that that's a SNOMED code on the far-hand side. And so we do have coding structures for some of what we need to do, but very, very limited coding at this stage. And of course there are other approaches to phenotypes that we can actually use to get into our computerized clinical decision support, but they're not mature enough yet. If we wait, we may be waiting quite a long time. But again, I'm sure there are people in the room who know much more about that. My wish or hope is that we will actually get to very quickly perhaps a bespoke list of 50 or 100 codes which could be authored almost on the back of a well, not a fag packet, a back of a pill packet, so that we could then decide which pharmacogenomic interactions we'd like to look at, talk again back to First Databank and Multilex to actually build those into their clinical decision support, and we could start to see some of this up and running very quickly. Going off at a slight tangent, you may be aware of the work that NHS Digital is doing to join up the IT systems for direct patient care. This is something that I hope you'll keep a close eye on, because it's something where there's a waning ambition, I think. The original idea was that GP Connect was going to connect all the GP system suppliers together, and then we would hopefully move on to an NHS Connect, a more broader interconnection of all IT systems, so that we can bring the coded data sets together at the point of care to feed into computerized clinical decision support. At the moment, this is going rather more slowly than we'd hoped. In fact, we're about to pilot a direct integration with EMIS using the same infrastructure that NHS Digital has been developing, but we will see very shortly a direct integration between GP system suppliers. This is taken from the GP Connect website. I'm not quite sure what this diagram means, because there are no arrows on it. To me, there should be arrows in all directions, that all information flows so that everybody can see what is going on. But there are considerable efforts across the industry to produce both HTML views, both an unstructured view of the data, so that at least it can be human readable, but also behind that the FHIR structured specifications that will, I think, in the near future provide this interoperability which will be needed to feed all the work that's being done in stratified medicine. I've slightly pinched a slide from Philip Brain, but I just want to talk for a few minutes, if I may, about how we get to really helpful, useful algorithms that can be built into IT systems. So I've taken his diagram and put it in my language. I hope you're aware of Research One. Research One is a not-for-profit arm of TPP, which just makes available data for research. It's not meant to be in competition with anybody else, but it was seen as a stopgap as we were successfully recruiting practices into System 1 and taking them away from their other research databases. So Research One is available for that. And what I'm just going to talk about very briefly is the Electronic Frailty Index that Andy Clegg has worked on with John Young in Bradford to introduce into all the GP systems now. This was a very straightforward, although I think it took them quite a lot of hard work, very elegant approach to defining a methodology to get useful information back into the GP systems. This was specifically trying to find out who are the most frail in the population. Of course, that is very important in terms of polypharmacy and adverse reactions to medication. And the approach they took was to take a large chunk of data from Research One, look at a number of deficits that shared common factors, that they were cumulative with age, they didn't saturate too early, and that they actually pointed to the particular characteristics of the population we were after. They used these particular list of deficits and from those pulled together over 2,000 CTV3 codes to feed into this, as well as the polypharmacy approach. The paper's in Age and Aging, and it talks about how the internal validation was produced and the Meyer-Kaplan curve that actually shows that it sort of fits with what you'd expect, and also the external validation cohort through the thin database. And this is now built into System 1 and into EMIS because the process was made freely available. And so practices can, this is made up data, I hasten to add, the practice can now find their most frail members of their population. But increasingly we're seeing other organisations now very interested in this, and people are looking at it to look at outcomes from ICU admission. There's somebody's looking at how this reflects chemotherapy outcomes, surgical outcomes, and so on, because it's obviously an important approach to risk stratification. And all of the data, of course, is just routinely recorded general practice data rather than specifically screening information. But from that, and partly based on our experience with QRisk last year, comes a sort of list of problems for system suppliers when you want to put algorithms or other support systems into IT systems. And this is a fairly simple and straightforward list, but goes without saying. So that one of the questions I'm sure will come this afternoon is how do we get system suppliers to do this thing, to get it up and running, whatever that thing is. And we're going to turn around and say, well, actually what we need is, we need a proper code set. We need to make sure we've got a validated code set for whatever code system we're using. We need to make sure we know what units of measure we're talking about, and we are, I think, almost unique in the country of receiving into a single database pathology results from almost every path lab in the country, and the variation in units of measure is bizarre at times. Not only, I mean, they form into, sometimes they're reporting on different tests, but they've only got a limited number of recodes to send the result in, so they're not, you can't compare them. Some of them are just errors, you know, the common juxtaposition of, I don't know, serum something or other in 24 hours, and we get the result in millimoles per litre. But from the same lab, we get the serum something or other spot test in millimoles per litre per 24 hours. You think, well, okay, well, let's just switch those around and get them right. And what is interesting, and what it's very much a symptom of, is that when the pathology messaging was set up, the people who had the expertise to set it up have long since retired, and actually there's, you know, it sort of drifts gradually, and we end up ringing IT departments who struggle to understand A, what we're talking about, and B, the importance of it. But anyway, that's a particular hobby horse of mine. The algorithm itself, of course, must be developed and available, and it must come with an appropriate test harness so that we can actually shove data through it and make sure that we're getting the right result. And then, of course, we must make sure that there are clear output behaviours expected of the clinician so that we can put clear information for the users of the system. But then we get into the difficult areas of what do you do with an incomplete data set? Do you have default values that you use, and how do you indicate that a default value has been used, or do you fail the algorithm at that point? Is the algorithm valid for an individual rather than a population? And if it is being used as an individual, if you alter the input parameters by putting in consultation data, should you rerun the algorithm, and is that behavior acceptable? And of course, the other issue that we're all facing in the NHS at the moment is that we're going to be switching coding systems soon away from Read2 and CTV3 to SNOMED, and there's the worry about the ongoing validity of this. So what can we be doing now? I can only speak obviously in detail for System 1, but I suspect other systems are very similar. A lot of the work around taking what's in the clinical record and doing something with it and returning some sort of result, we can already do. We have well-established client-side APIs which are freely available for integration. So, for example, the API can receive, or rather the API will transmit all of the coded information that's in the patient record into a thing, and that can be a web service that can then interrogate it and say, well, actually, this patient has got this issue, and send the message back into the system. So that's available now. The organisation groups aspect is much more for where you've actually got a defined approach you want to use for a certain group of patients, and it may be a number of reports, and perhaps you want to prompt the users to put a specific input which will then determine the next stage of their behaviour. And these can all be created and delivered within organisation groups. So you can recruit practices into an organisation group, and a skilled user can use the tools within the system to create the infrastructure and share it back to those practices. And that's a nice way of testing stuff. It's very nice for me because it's not in my hands, and nor am I responsible as a medical device or not as to what's going on. We talked about Research One, but of course also we do provide data extracts into data warehouses for whatever our data controllers want to use their data for. And then of course the final thing is, and there was a slide I glossed over earlier, is to how you do risk stratification fairly and legally, and whether it should be done with identifiable information or whether it should be pseudonymized or strongly pseudonymized. We also, if we're working in a pseudonymized arena, need to be able to feed back that information to the GP, so that if you've got a group who need an intervention, and we have a methodology that we can use to do that as well. So I think that's a very brief picture of what I would expect current IT systems to do. That's only scratching the surface as we move forward. We have much bigger questions about how you plug in a couple of gigabytes of genomic information about a patient into a record and search for the relevant stuff. But I guess we'll develop that as we go along. So that's all I'm going to say. I'm very happy to take any questions. Hope that was of interest to you.